Welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, 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 and welcome to another exciting episode of Brain Chat with the Nerdy Neurologist. My name is Dr. Mitzi Joy Williams. I am the Nerdy Neurologist, and I'm here to talk about an extremely important topic, which I'm really excited about, and I am so excited about the guest that I have here tonight. But before we get into that, first we want to thank our sponsor, the National MS Society, for sponsoring Brain Chat, and to all of you who are logging in, thank you for taking the time out to spend some time and educate yourself about neurologic conditions such as multiple sclerosis, and today, NMOSD. All right, so log into the chat. Let us know where you are viewing from. I bid you greetings from Atlanta, Georgia, and I hope that you guys are having a great start to your week. All right, so let's get right into it because I've got some amazing guests with me tonight. I am so excited to have with me Sumaira Ahmed, who is the founder and executive director of the Sumaira Foundation. Welcome, Sumaira.
Hi, I'm so happy to be on your show again.
Yes, and so you are a Sumaira among several Sumairas in my life, but you are also my Sumaira, like my other Sumaira. So it's great to have you back. And then we also have Dr. Michael Levy, who is an associate professor of neurology at Mass General Hospital and is a specialist in neuromyelitis optica and neuroinflammatory disorders. Welcome.
It's a joy to be here.
Awesome.
Yeah, good one. That was a good
one. My middle name is Joy, so I know all about the joy. I bring the joy. All right, so before we get started into the questions and talk about NMOSD and break it all down, first, I love to hear about how you got involved in the neuroimmunology space. I'm going to start with you, Dr. Levy, and then Sumaira, I want you to tell us a little bit about your journey and kind of how you got involved with advocacy.
Well, I was a neurology resident at Johns Hopkins Hospital in Baltimore, and I spent a lot of nights inpatient on call. And the cases that kept me up at night, the ones that I would just read about all night long, were mostly ones where the immune system was attacking the nervous system. And in Baltimore, a lot of these cases ended up being neuromyelitis optica. At the time I was training, the blood test for NMO had just been discovered.
Wow.
These people were in MS clinics being misdiagnosed as MS. They actually had NMO. Wow. And they were in trials and they were on MS drugs and they were doing poorly. They would end up in the hospital with me. Then we would diagnose them and the MS docs were happy to have me take them away. They didn't want them in the MS clinics. The MS drugs were bad for them. They were messing up the trial. So we started an NMO clinic in 2009. And we saw over 500 patients before I moved here to Boston.
Wow.
We established the NMO clinic and research unit here. We've expanded beyond NMO to MOG, autoimmune conditions. So we're not just NMO, but NMOSD is where I got my start.
Yeah. So it's all about those things that kind of keep you up and hold your interest. When I started my first rotation in the MS clinic, I was like, oh, this is where I need to be. And so it's really cool. I think the other cool piece is that I knew that going into the field of neurology, that things would change drastically in the course of my career in my lifetime. And so it's been so amazing to see the advances, in these fields. Every medical specialty makes fun of each other, right? So neurologists used to be diagnosing adios, right? Because there was nothing we can do. But that's no longer true. And so it's been really cool to see the advances in the science and to see how we can now treat people and how people are doing so much better than they were, when we started, when I started 20 years ago. So Sumaira, tell us a little bit about your journey and how you became such an amazing advocate and the founder of the Sumaira Foundation.
I'm going to give you the very, very short version.
Okay.
Actually, 10 years ago now, I myself got sick with seronegative neuromyelitis optica after sudden vision loss and weakness and numbness and, all those classic symptoms. And thankfully, I was a patient. I'm still a patient at Mass General Hospital, where Dr. Levy is now. We're very lucky to have him. And I was diagnosed within 5 weeks of my symptoms. And though I felt very fortunate to have been diagnosed early, be put on, therapy that was available at the time right away, had all the right specialists on my team, people, caring for me and people who knew about these diseases, I still felt as a newly diagnosed young patient that there was something missing for not Samira the patient, but Samira the person who just got diagnosed with this. And my heart and my mind, they were so in desperate need of community and support and meeting other people and seeing that there was advocacy going on. But, at the time in 2014, when I Googled NMO, nothing good came on that first page of Google. It was very devastating. It was terrifying, and nothing was positive. And I think I myself am probably a very naturally positive, happy, upbeat person. And that what Google showed me wasn't enough for me. And so I said to myself, I had a very honest conversation, like, okay, the prognosis is not good. At that time, that was the case. And if I do, in fact, have a limited window of time left while I'm on this planet, maybe there's something that I can do in my very, very small way to not just raise awareness, but to build a community, an international community of patients, and also elevate our voices to make sure that we are also heard and not, just living in the shadows of MS from here on out. So I acted very quickly from my hospital bed, and I Googled, how do you start a foundation? I hired a lawyer. I kind of made things happen very quickly. And now we're 10 years old and global and growing. And it's been quite a decade, I will say, both as a patient, but also as an advocate, but also just seeing how much has happened in NMOSD and MOGAD over the last 10 years. It's really inspiring to see. And, I just very, very quickly, I just want to say, Dr. Levy is one of the most modest doctors and humans I've ever met in my life. But I will never forget the first time that I met him in person. It was at Harvard in 2016 during a blizzard. It was a patient day happening, and they flew him in, and I was totally fangirling. And he was so kind. He still is. And really like one of the heroes of our community. And I will also never forget the fact that he visited me in the hospital when I had my last relapse 5 years ago.
Wow. Wow.
Yeah.
So let's talk about it, right? So, you said 10 years ago when you got diagnosed, you Googled, there weren't very many resources. Dr. Levy, you mentioned when you were in residency training, the test just became available. Tell us a little bit kind of about the evolution of our understanding of NMOSD. I remember when we used to kind of include it as a part of MS, right? We were like, okay, DVIX is a type of MS. And then all of a sudden it's not. There's a specific antibody. So tell us a little bit about that evolution of our understanding and how that's changed over time.
Well, it's all in the name. Neuromyelitis optica was coined because MS was called neurocerebritis. The brain was the center of the disease in MS. And Dr. DeVick, even in the 1890s, 130 years ago, recognized that there was a type of disease that looked like MS, but was not neurocerebritis. It involved mostly the spinal cord, myelitis, and optic nerves, optica, neuromyelitis optica. So he published a series with his graduate student of 14, 15 cases that were distinctly different. But it wasn't until 100 years later that the Mayo Clinic went back and found all of these patients that really met that definition of DEVIC's case series. They put them all together. They found this antibody that was in common among these people. And then they published this antibody test, 2004. Wow. And within 2 years, it completely changed the field. Every lab was using it. We were pulling patients out of MS clinics that didn't belong there. And just between that time, 2004, when the antibody was discovered, 2019, we have 3 FDA-approved drugs.
Wow.
So that's 15 years. Not too bad, I think.
Amazing. Like lightning speed, right?
Medicine, I would say.
For medicine, right? So after the 100 years, it was lightning speed, but then there was the 100 years in between. But yeah, I mean, so much has changed in such a short period of time. So the main differences we think about when we think about NMOSD is we think about, obviously the spinal cord is involved, but can the brain be involved? So I remember a time, the diagnostic criteria has also changed over time, because we used to say brain was not involved, but now we know that the brain can be involved, particularly the brainstem. There's certain syndromes. It just doesn't look quite the same as MS. Can you talk about that in a little bit more detail?
Yeah, we used to be a diagnosis of localization. That's how Dr. DeVick described it, myelitis and optica. But now that we have a blood test, we don't limit it by localization anymore. And we have had lots of patients with brain disease, brainstem, like you mentioned, area postrema attacks causing nausea, vomiting. So if you test positive for the antibody, then it doesn't matter where your lesion is anymore in terms of the diagnosis. We know it's NMO.
Yeah.
NMOSD.
NMOSD. Yeah. And so, I think that that's really important, and as you said, one of the important things about diagnosing is that some of the treatments for MS can worsen NMOSD, so it's important for people to be diagnosed correctly. So let's talk about seronegative, right? So Samira, you mentioned that you were seronegative, which means that your antibody tests were negative. So what is our approach to, managing those patients, Dr. Levy?
Approach to managing seronegative is trying to figure out, first of all, if there's something else that better explains the condition. But assuming you can't find anything and you're diagnosed with seronegative, like Samira, it's a little bit of a trial and error among a few drug options. The drug options are limited to ones that we have access to, which means they can't be millions of dollars. They have to be affordable, like rituximab, or like mycophenolate, or sometimes prednisone steroids, which we don't like to use long term. And then we just trial it. And if it works, great. And if it doesn't, we try something else. That's really the state of the art at the moment, unfortunately. We need better biomarkers to start parsing out cases like Samira's to understand really what disease they have and what they would respond to.
Yeah, so extremely important, so whenever I see someone that comes in with concerns for demyelinating disease, if I'm concerned about MS, I always test them for NMOSD. I also always test them for anti-MOG antibody, just to make sure that I'm not missing anything. What is the best type of test that people should receive, right? So we're learning now more about the type of testing, right? Obviously this is for a patient audience, but certainly, we certainly empower people to know what type of testing they should ask for. There's a difference between, let's say, the ELISA test and some of the other tests. There are some that are more specific. So which one is the most specific, for people to be tested with?
The cell-based assay is definitely the most specific, although the sensitivity of both tests, meaning how many times can people be tested who actually have the disease but test negative, the sensitivity might be about the same, somewhere 80-85%, but the specificity, meaning if you test positive, you definitely have NMO, that favors a cell-based assay. Because there have been enough of these false positives with the old ELISA assays. And I don't want to say anything bad about any testing company, but there are still some, like ARUP, which is the largest testing center west of the Mississippi in Salt Lake City. And they still use the ELISA assay. And it might be okay to start off, but for these difficult cases, especially seronegative, I would retest with the cell-based assay, which is offered by Quest and LabCorp and Mayo Clinic.
So Samira, going back to you, tell us a little bit kind of about your diagnosis kind of journey, right? So you're young, you get diagnosed, you start this community. What was it like kind of interacting with other people? Did you find that your experiences were similar? Were there some themes that you saw across, such a small community of patients? Or
Yeah.
did you realize the community was much, much bigger than you ever anticipated?
Oh, maybe a little bit of both, because so I should also say that there was already, there were already two organizations for NMOSD and transverse myelitis at the time. So, but they were very, very focused on research, at least at the time. So I didn't necessarily gravitate towards that in the beginning, but very respectful of all the work that they've done over the years and their contributions. But I looked at Facebook and I found this Facebook group that already existed that had maybe like 1,000, I think, people at the time, 1,500, which I was like, whoa, that's a lot of people. And so even before I decided to start an organization, I joined this group and I introduced myself. Everyone was super nice. And you got to see that there were people from Minnesota, from Wyoming. It was very American focused at the time. And I listened and learned for the first couple of weeks of my diagnosis and read a lot. I was observing all of these conversations, and there were definitely a lot of themes. I think that people, especially back then, really did feel like we were not being heard. We were not being seen. We were not being recognized for having this very different disease than MS. MS was still so much the part of the identity of NMO patients at the time. And I think that's sort of where I got the idea that, hey, like, I think we need to do a better job as a community to make sure that we are heard and seen, and that we can identify as, having this very different disease that has its own antibody. So sorry, I don't even remember the question, but there was quite a bit of a community online. I did feel it was very American, which is great. But what I got to learn even soon after that was that 95% of our patients were actually outside of the US. And I did, I was just doing some simple math in my head. Facebook at the time was the largest social media platform with over 2 billion users, which means so 2 billion out of 8 billion people in the world were on Facebook, and 1,500 of us were in this group with NMO. So on the one hand, I was very excited to see that there were 1,500 people in this group. But on the other hand, I was doing the math and I was like, okay, wow, we are a really small bunch in the large scheme of the world.
Yeah. So about that, so Dr. Levy, tell us a little bit about kind of the incidence, prevalence of NMOSD. Where is it most common? So you have a large clinic or have had multiple large clinics. I live in Atlanta, Georgia. I've not seen a clinic in our part of the country with that many NMOSD patients, so usually I might have 10, you might see 15 or 20. But tell us about kind of the incidence of how it's occurring, in different parts of the world.
Yeah. In most parts of the world, if you look at the number of cases per 100,000 people, it's remarkably constant, somewhere between 1, 2, 3, 4 people out of every 100,000. That's in the US, in Europe, in Asia, in Australia. That's all about true. In some part, there's one hot spot in French Martinique, which is it's a colony of France, and they have a national healthcare system. Every person on the island is registered, so we know every case of NMO there. And in that population, it's 10 per 100,000.
Wow.
And what's notable is that they are 90% Afro-Caribbean ancestry. And we know even in the US that African Americans are overrepresented. They make up 40% of the NMO patient population and only 13% of the general population. So they're over threefold overrepresented.
Yeah. So very interesting. Yeah. We're learning a lot about, African-American populations and other populations with multiple sclerosis, and that the incidence is much higher than previously thought, and so when we think about MS, some of the older statistics suggested that, Black or African-American patients had more optical spinal disease, meaning eyes and, spinal cord affected. But now we're going back and saying, well, maybe some of those people that were in those earlier studies actually had NMOSD, so there's not a way for us to kind of go back and, totally look at those populations. But, the suspicion is that, there probably were a lot of, or some of those people in the earlier studies characterizing MS patients with poor outcomes who probably had NMOSD and weren't on the appropriate treatment for it because they were being treated like they had MS. Any thoughts about that?
It's true. I don't trust a lot of the studies in MS prior to antibody testing for NMO. And similarly, I don't trust a lot of seronegative NMO studies prior to MOG antibody testing, which became available in 2017 in the US, 2015 in Europe. Yeah. And as we learn more and more, I think I'm going to start doubting more of these papers as making more accurate molecular diagnoses.
Doctors, can I ask you a question?
Sure.
Both of you, actually. Why don't we test all MS patients for NMOSD and or MOGAD?
So that's a great question. I personally do test everyone. So, one of the things when we think about demyelinating disease, we often think of it as a diagnosis of exclusion, right? So we're making sure there are not other reasonable causes, for you to have whatever symptoms, numbness, tingling, et cetera, et cetera. So when I am doing a battery of tests, I kind of screen for rheumatologic disease. I routinely check everybody for NMOSD and MOGAD. So that's just part of my battery of tests. Even if it looks a little bit more like classic MS, again, because it's a spectrum of disease, sometimes you may be missing something. So I test everybody. That is not the practice of all of my colleagues, but certainly if you have any thoughts on that, Dr. Levy.
Yeah, I've heard the argument that if you test everybody, then you're going to capture some false positives, meaning they test positive, but they really don't have it. Right. And I would say for alkyl 4 antibody, there's no such thing. If you're being evaluated by a neuroimmunologist for MS and you test positive for the alkyl 4 antibody, the diagnosis, the workup is done. Diagnosis is NMO. MOG, not a full story yet. We have work to do to improve the MOG antibody. But as far as NMOSD goes, I do think everyone should be tested. The price of the test is coming down. There's really not much excuse. We're getting MRIs, which are $2,000. We're getting 10 blood tests for other mimics. NMO should be on that list because it's the one thing that would really change the treatment plan.
Totally.
Absolutely. And, I remember a time where we used to have to send out the test and it was expensive. And sometimes insurance companies would deny it if someone had more kind of classic MS symptoms and people could not afford to pay for the test out of pocket. But as you said, it's less expensive. It's not free. Although I've been urging some of our collaborative friends that they should pay for it and it should be free. But, I think that it's accessible enough to where there's not a reason not to test. So I think that has not filtered down to everyone in the neuroimmunology community, but I think certainly for some of our newer, neurologists who are, definitely much more aware of these conditions, I think that it is common practice to test for it proactively in anyone with demyelination. So let's talk about MOGAD. So we've been mentioning it, we've been saying it kind of in the side. What is MOGAD?
Well, MOGAD doesn't have a pretty name like neuromyelitis optica.
Right.
It gets its name, it's MOG, myelin oligodendrocyte glycoprotein. It's simply a protein on myelin, which in mice was found to trigger an immune response that would mimic a demyelinating disease. You take MOG from a rat, inject it under the skin of the mouse, and it would get transverse myelitis, optic neuritis, transverse myelitis, and brain disease. And MOG was the principal part of that trigger. So we've had this mouse model for a long time, but we always thought of it as MS. And a lot of MS drugs were developed in that mouse model. Maybe that's why MS drugs aren't that good for MS. Copaxone, Avonex, a lot of these drugs were developed in the MOG mouse model. And it wasn't until over the past 25 years or so that we've identified the MOG antibody in people. And these people kind of look like MS.
Right.
And so we called them MS for a while. A big 2003 paper suggested MOG antibodies identified MS people. And that was debunked.
Right.
Eventually, we figured out, no, it doesn't identify MS, and it doesn't identify NMO, who are aquaporin 4 positive, but it does fit nicely in between MS and NMO, and also right under ADEM. There's that little Venn diagram overlap there that we call MOG, or MOG antibody disease, or MOGAD.
And so what are the differences between MS, NMOSD, and MOG?
Minor differences. MOG tends to be more optic neuritis. 40% of MS people get optic neuritis. Lots of people with NMO get up. It's hard for anybody to go online and say, I definitely have MOG or I have NMO. Even when I see people in the hospital, I kind of scratch I don't know if you're MOG or NMO. We just have to get the blood test.
We got to get
the blood tests are pretty good now. For aquaporin 4, they're near perfect. For MOG, we're working on it, but they're still really good. If you're thinking about getting a MOG test, now's the time to do it.
Yeah. Yeah. So, Samira, tell us a little bit about your outreach to the MOGAD community. So, I know that, you were diagnosed with NMOSD. That became something you're interested in. How did MOGAD get on your radar? Because I remember, I think the last event we went to, there was a resolution talking about MOGAD. Tell us about how you got involved with advocating in that community as well.
Well, I think it started from a group of seronegative NMO patients who were all of a sudden finding out that they have a positive biomarker for MOGAD. And so we said, well, we've been friends for so long, you've been part of our community for so long. We're not going to kick you out. It's like cousin diseases. Like, let's just stay together because the doctors are the same. The therapies largely are the same, whether acutely or, as a prevention therapy. But it became, there were so many more patients who were getting diagnosed with MOGAD because of the biomarker that became commercially available, in 2017? So I definitely didn't feel it was right to kick these people out or alienate them just because they have a different biomarker now, but still something so similar. So it was a natural sort of progression and growth. And, I think in 2019 or so, I kind of said to the TSF people, I'm like, guys, we're going to change some things around here. Instead of it being the Samira Foundation for NMO, we're just going to be the Samira Foundation, and we'll advocate for both NMOSD and MOGAD. I don't want anyone in our community to feel like they don't have a place, that, that now their voices are going to be lost in the shadows of MS somehow. So yeah, we just said, I'm Sue Mama. This is the foundation for us all. Come to me, no problem. I understand you. And by the way, I very well could have MOGAD myself. I don't know. I mean, I test negative for everything all the time, but who knows if in 2014, when I got hit really hard with this, my first attack, what if I had tested positive for MOGAD at the time? Like, we don't know. So it really comes from this place of inclusivity, community, keeping us together. I think there's a lot of strength in numbers, especially on a policy front. So it was a very easy decision to say, we're going to help the MOGAD community too. And over the last 5 years, I think we've probably funded about $500,000 in MOGAD research.
Wow.
We have 12 MOGAD ambassadors as part of our organization. MOGAD has equal representation on our website. And, we try to support where we can, but very important, in my opinion, to not separate us from each other.
Yeah, I love it. I love it. So important. So let's switch gears a little bit and talk about treatment. So, we talked about how the treatment has evolved and changed over time, how we now have FDA approved treatments for NMOSD. We don't yet have FDA approved treatments for MOGAD. But talk to us a little bit about the treatment strategy. And I think particularly why it's so important to be diagnosed correctly and treated early.
Well, for NMOSD, we do know that some of the older MS medications are harmful, and even some of the new ones. There is some overlap. We use a lot of B-cell therapy, B-cell depleting therapy, like that they use in MS, ocrelizumab, ofatumumab, ublituximab. B-cell therapies in general also work for NMO. We have different versions, rituximab and inblizumab. These are just names that are drugs that deplete B cells, and that mechanism seems to overlap and work well for both. So that wouldn't be harmful. But B-cell therapies don't work that well for MOG. So you have to be sure you don't have MOG before you start one of those drugs. But there are 3 approved FDA treatments for NMO, and those are the ones that I advocate the most because they have the most data, scientific data to support it. I could tell you till I'm blue in the face about my experience with this drug or that drug, but it doesn't compare to blinded placebo-controlled data that you get from trials in NMO. So we do have 3 drugs, and they're all relatively effective, safe, and tolerable. And so what I do is I present the data to patients. I present efficacy, safety, cost, everything. And then I say to the patient, what's your priority? And then let's see if we can find the best medication for you. It's a shared decision-making model. I think in the end, when people buy into the drug that they pick, they're more likely to stay on it. And that's one of the keys for efficacy.
Yeah, absolutely. So what does that shared decision-making look like for you, Samira, when you're sitting with your neurologist and talking about, what's the best direction to go?
It's a conversation, it's a dialogue, it's a relationship, and it takes 2 to tango. So I'm really happy that we live in a day and age where shared decision making is so much a part of our care, because I can't imagine having to go on therapies that have long-term, short-term side effects and feeling forced to go on something just because my doctor said, nope, this is the one you have to be on, unless that is the only option. Like, that's usually not the case anymore for us. And I think shared decision-making becomes of utmost importance when a rare disease like NMOSD is so lucky to have options in therapeutic treatment. So now that we have 3, almost 4 FDA-approved therapies, it's so important for patients to establish and physicians to establish this dynamic that includes shared decision-making, because it's, you're not just treating a patient, you're treating a person who has hobbies. I'm so sorry, somebody's screaming outside, but a person who has dreams and hobbies and a life outside of just having a disease. So you have to have that conversation with your doctor about what's important for you and make a decision together, because it affects everyone, essentially.
Absolutely. And then the other piece that I think is really important is that, with NMOSD particularly, sometimes the relapses, the episodes can have very devastating consequences. We can see it with MS, but sometimes there's more severe disability that can occur. So we really want to prevent attacks. And so I think that's another key reason why it's so important to be diagnosed accurately and have a conversation with your neuroimmunologist, your neurologist about getting on treatment early. I have some patients with MS who want to kind of wait and see, or, do diet and exercise. And certainly, we advocate for those natural lifestyle modifications. We also advocate for medication because we know that it works from those placebo, from those trials, those clinical trials. But I think, again, for NMOSD, I definitely have a real conversation with my patients like, listen, we do not want another attack. We've got to get you on some type of treatment as early as possible. Yeah. So, that time went by really fast, guys. But, before we go into kind of, what resources are available, what about treatment for MOGAD, Dr. Levy?
Treatment for MOGAD, there's no FDA-approved drug yet. There are 2 trials ongoing. I think maybe we can link to those.
Sure, absolutely. We can put those resources up.
And but we do have some off-label options. IVIG, intravenous immunoglobulin, and mycophenolate are 2 options that I usually offer in my clinic. Not that they're supported by strong data, but some experiential data.
Okay.
So
gotcha.
It's not something that I would just dismiss, say, go home, there's nothing we could offer you. I'd never do that. But just not quite the level of scientific data we have for NMOSD yet.
Yeah. And so how rare or how common is MOGAD?
Actually, it's about 3 times more common than NMO.
Really?
Now that we're looking for it.
Right.
Yes. But
interesting.
But half of those cases never relapse. So they'll come in, they'll have their optic neuritis, they'll test positive. Maybe that was they usually test positive at the beginning, as Samira knows. but then about half of people will never relapse.
Wow.
So I think those are a lot of the people that we haven't captured up to now. And it does suggest that maybe people who have just one attack, they don't need preventive treatment. They may just remain monophasic.
Yeah, that's what we hope for. We would
I
love.
was just going to say that's the dream.
We would love a one and done. We would love a one and done.
Scientifically, we want to know why that happens.
Right.
Because if we could push everybody in that direction,
that would be the goal.
Medically,
yeah. And you also wonder if maybe some of those folks, you know, back in the day, as my 6-year-old would say, she's into back in the day. Mommy, were you around back in the day? So back in the day, you know, you used to have this category called benign MS, right? Where maybe people would have an attack and go completely back to normal. And, you know, now that I'm thinking about it, I wonder if those people were possibly MOGAD, you know.
I think so.
Yeah, because we don't use that category anymore because people are like MS is not benign. But I wonder if some of those folks who had one episode and maybe never had anything again, if
you ask them, they're not quite back to normal, right, Samira?
Yeah.
Even after you heal really well, you just never quite yourself again. But benign is a fair comparison to MS patients who progress.
Yeah.
Dr. Levy, how many of the monophasic patients are pediatric?
A lot. So that's fair. A lot of the monophasic cases, there'll be the 7-year-olds with ADEM or optic neuritis, and then they'll kind of grow out of it, is how pediatricians used to call it. But a lot of them have ADHD later in life, other troubles in school. It's not benign.
Right.
So we do need to take better care of these patients.
Right. Yeah. So even if it is monophasic, meaning one episode, it does not mean that there is not any leftover disability or other issues that may occur. But certainly we'd rather have one episode instead of recurrent episodes with accumulating disability. But, you know, monophasic doesn't necessarily mean you go back to normal and everything's as it was. So, but yeah, so this has been a really interesting conversation. You know, I'm always excited about the science, how things have progressed and changed over time. You know, as I said, I went into the field of neurology because I just knew it was going to be an exciting journey and that there was so much to discover and that I would see so many things change in my career and lifetime. And so I'm excited to see that. You know, thank you, Dr. Levy. Thank you, Samira, for your amazing words of wisdom and advice. What words would you give, kind of parting words for those patients out there who may be newly diagnosed and new to the NMOSD community? What would you say to them as they're watching this? I'll start with you, Dr. Levy, and then
I would say call Samira.
Definitely call Samira. We'll put her phone number in the chat with those clinical studies. No, I'm just kidding.
I will say this about NMO and MOG. There's always one piece of good news, and that is that compared to MS, there's no progressive phase. So if you can stop the relapses, you can stop the disease. So there's a real emphasis on preventing relapses. That's the one piece of good news.
I love it. I love it. What would you say, Samira?
2 things.
Join the Samira Foundation. Talk to the ambassadors.
Of course. But there's 2 things that I wish I was told when I was first diagnosed. So the first is there's a bit of a roadmap to success, if you will. Of course, it starts with a correct and early diagnosis, if possible, finding a doctor who really knows and understands your disease and that you vibe with, because that's important. Get on a therapy that works for you and lean into your support system. I think there's like 4 very simple-ish ingredients in theory to live successfully or as normally as possible with something like this, if in the most fortunate of circumstances. I recognize that. And then the other is, it's been absolutely fascinating to see how advocacy has just kind of blown up over the last 10 years, and not just in NMOSD and MOGAD. I think in rare disease in general. When I came on the scene 10 years ago, it was sleepy, I have to say. I'm sorry. It was a bit sleepy, which is why I decided to do something. It was quiet. It was not the fire wasn't there. And now I see advocates left and right, and I love it because I'm like, this is great. People are realizing that they can use their voice for positive change while also empowering themselves. So, the words of wisdom from that is advocate for yourself, because you know your situation better than anybody else can likely articulate it better than anybody else.
I love it. All right. And then last questions. I know I said the last one was the last question. What are you excited about in the field?
Michael, you go first.
I'm excited about research in the immunology of NMO and MOG, because now that we have been able to calm the disease down, we haven't cured it. You have to stay on these medications to avoid a relapse. What we're doing now is really trying to re-educate the immune system so it doesn't want to attack anymore. So then you can come off the medications. I know that makes a lot of people uncomfortable, but that's really the goal, is to treat the disease without lifelong immune suppression.
I love it. What are you excited about, Samira?
Similarly, the research and the science, which 15-year-old Samira, who was failing science in high school, would never believe that she'd be saying this 20 years later. But yeah, I think the research and science that continues to progress as quickly as it does is really inspiring, and it provides a lot of hope to patients. And particularly, I'm excited about seronegative research because I think there's so much to unfold and discover. And a lot to learn about seronegative cases across the board in neurology.
Yeah, I love it. Well, thank you all so much for your time, your expertise. I know that our Brain Chat audience got so much out of this amazing conversation. And thank you to all of those who have tuned in to watch this episode. Thank you, Dr. Levy. Thank you, Samira. Have a great night, everyone, and we'll see you in 2 weeks.